It's a case of a male of 50 years old. He is alcohol and tobacco abuser. He presents two past alcoholic acute pancreatitis and a recent acute pancreatitis in January 2015. A CT scan shows a cystic lesion of the head of the pancreas with dilatation of the AMPD without necrosis. EUS FNA confirms the presence of a pseudocyst with an ACE level of 48 nanogram per milliliter and lipase of 99,000. The MPD presents a dilatation of 6 millimeter. So we propose to investigate with an EUS elastography and to perform an ERCP with pancreatic sphincterotomy. One study of Iglesias and al. Have studied the ratio elastography in chronic pancreatitis in 2013. 191 patients were enrolled, and a comparison between elastography and Rosemont classification was done. A direct linear correlation was found between the number of EUS criteria and ratio elastography with an accuracy of 91%. So we go to the room 2 with Dr. Devier and Dr. Iglesias.
Well, we have already started the case. I have by my side Jacques Devier to try to focus and try to solve this case. We were thinking on a case of a chronic pancreatitis patient with a cystic lesion in the head of the pancreas. And whenever in my unit I try to evaluate a patient for chronic pancreatitis, I always focus on the body and tail of the pancreas to see the features of chronic pancreatitis. And we are now in the body of the pancreas, and we can see that we have an almost normal parenchyma. So there is really no features of chronic pancreatitis in regarding parenchymal criteria. And we're speaking about elastographic. We can just make an elastographic evaluation of this pancreas, and it can really be helpful to try to, with the frame average, to see that really the behavior of the parenchyma is very close to normality, with a mainly green and some red areas. So this is not really a very hard tissue in terms of parenchymal evaluation. However, what we found, and we go on try to evaluate the case, we are really seeing something here that is really dilated, and this is the main pancreatic duct, and this is really dilated. So this is really one of the signs of chronic pancreatitis. You know that we have both parenchyma and ductal signs, and this is one of the signs of chronic pancreatitis. However, it's quite strange to find a normal parenchyma with a dilated duct and think just in a chronic pancreatitis. So in this case, we need to find out why this duct is dilated, and probably it's not only related to, or maybe not related really to chronic pancreatitis. So we are here, we can go to the tail of the pancreas, and we can see that this is quite normal, and even the duct in this part becomes more normal. We can say that it's quite irregular. We see the kidney in the deep part of the image. We go to the tail. We can rule out the presence of any kind of lesions, and the parenchyma looks normal. Now we go to the spleen, the kidney, the suprarenal gland, and we go back again to see the pancreas. And now we're going to focus on the duct, because we see that it's irregular. We have some dilated side branches surrounding the duct, so we need to focus on the duct on to see what's going on. So
it was also important to notice that the patient had no pancreatic calcification.
Exactly.
He has no history of huge alcohol intake, and this was the first acute pancreatitis that he presented. So we might be close to the initial pain episode or pancreatitis episode in this patient, whatever the cause of this acute pancreatitis was.
In fact, we now are focusing going from the body to the neck of the pancreas, and we see clearly there is a dilation and a narrowing main pancreatic duct while we're going to the head of the pancreas. So it's really a change in the size of the duct. So we're going to focus now, and we're going to go to the head of the pancreas to complete the evaluation and to see the cystic lesion that was previously punctured and emptied. So I need to say that we're using also the slim scope. That's very nice to use in these cases, because you can easily go everywhere to the two and also to make all of the movements to see whatever station for the pancreatic evaluation with very smooth movements without almost any compliance, even to go to second part of the duodenum. So now we are going to focus on the head of the pancreas, and here we can see an even more dilated main pancreatic duct here. Here we have the common bile duct that is normal, but we can really see in the image a dilation of the main pancreatic duct. So we are moving to the neck, and we are going now to follow the main pancreatic duct more close to the ampulla to see what's going on and to see, because we expect to see some narrowing of the duct in some position to explain why it's dilated. So here we are very close, and okay, this is the cystic lesion that was previously punctured. And we see where Jax is showing us the narrowing and the stricture related to the main pancreatic duct, and we see how it starts to dilate after that stenosis. So we can clearly see, based on AUS, that there is an stenosis of the main pancreatic duct very close to the ampulla, and also very close to this cystic lesion. Now we are moving, and this is the ampulla, so we can see the common bile duct in the up. That's the common bile duct, and we see down the image. Here we can see the beginning of the main pancreatic duct. We see the cystic lesion, and we follow the duct, and we see the narrowing and the stricture of the main pancreatic duct. So probably this is the cause of the dilation of the patient, and probably this is a cause of pain. I mean, this is a structure and a patient of pain, and probably this is the origin of the problems of the patient. So probably, and we have Jax here as a good indication for a pancreatic stenting.
Yes, and the thing which is interesting too, because the cyst is very small, 1.5 centimeter. But if the cyst would have been a little bit larger, the cyst is also a good opportunity to decompress the main pancreatic duct. And we know that if we are in trouble, this is another opportunity to decrease the pressure of the pancreatic duct, because we know that, of course, it's communicating. Since Mark did a puncture, and I'm tired the cyst 1 week ago, I think, to confirm that it was a pseudocyst with very high lipase and low CA.
And in fact, there is some images here in which we can see that is probably in this part of the image, there may be a connection, as Jax is saying, between the cystic lesion and the duct. If not, it should not be, the cystic should disappear, but it's just relapse. So I think this is a good indication for an ERCP.
Yes.
So I will just change and give the ERCP scope to Jax to perform the ERCP.
We just start the exam with this tritome. Reviens avec ton guide un peu. With this tritome, the papilla was looking normal. You see that the 3-lumen sphincterotome allows you to inject and manipulate a guide wire together. We have an acrobat guide wire inside, which is a straight one, which is not my preferred one if I have to get deep cannulation, because we sometimes need a J1. So we will do an injection now. If you have the fluoroscopic image, I'm pulling back a little bit just to make sure that we give a chance to be in the axis of the pancreas. What's there? Ah, yes, here we are, here we are. Inject a little bit more, Sonia. And then we will play a little bit with the wire to see if we can pass the tight stricture, which is, as Julio showed, a very tight distal prepapillary stricture, so the ideal case for an endoscopic treatment. Is the wire advancing or not? Okay, here we are, fantastic. You know that endoscopy is most often not the work of the endoscopist. Now, the endoscopist is just there to hold the endoscope and the catheter, but the guide wire work, especially in ERCP, is the technique of the assistant, and the assistant are usually much better than the endoscopist in manipulating the guide wire. However, as I did with Mark many times when we are sometimes traveling together, it's always useful to have a doctor who can manipulate the guide wire too, even if it's not as good as So we can inject a little bit more, but not too much, but just to see if we have a communication with. Inject.
Do
Okay.
you have a communication with the cyst, Jacques?
This is what I want. I think we have one
Yes,
there.
because
But I will not inject more because I don't want to induce an
Oh, yes,
acute
perfect,
pancreatitis in this
perfect.
patient. And now Sonia was making a loop to go in the body and tail of the pancreas. So again, oops, fantastic.
when you finish the sphincterotomy, we just move to see the biopsy and we come back for the stent insertion. Huh?
Yes, so
Okay.
one important point is that for the pancreatic sphincterotomy, I know there are no data, just a little bit of experience. I use the pure cut and not the endocut because I'm extremely afraid about secondary stenosis. When you use a pure cut, you do the endocut yourself, you see. You make a very nice section, avoiding the zip section. And I like to see this section up to the time that I have a view on the distal part of the pancreatic duct. I think that for this patient we are not far away from the maximal size. Look, what's that? Would it be some proteic fragments? No. Always have a look also at the You see, now we have a spontaneous flow of pancreatic juice, so we are not far away from a complete section. We have a little bit of blood, but this is don't coagulate if you have such a small amount of blood. Just cut a little bit more. And now I think it's probably enough for this patient.
Okay.
So we just finished the dilation with a 6 millimeter balloon, and I will show you the placement of two stents. We will place two 5 centimeter stent, and as I mentioned, this is a very small structure. I'm almost sure that we can get a calibration with one period of 6 to 12 months of stenting if we are able to place two stents. So I will place a first stent which will be a 8.5. I will do an intraductal exchange of the guide wire, and I will place a second one which will be a 7 French. Just to tell you when you were moving, because we know that we have to save time, we did the dilation, but we saw, as Julio has described, a very nice imprint on the balloon, which was corresponding to this very short prepapillary stenosis. On y va? On y va?
One question.
Yes.
Do you perform a prophylaxis of post-ERCP pancreatitis in this case or not?
Yes, of course. We will, every time we work on the pancreatic duct, we give NSAID to the patient, and the patient has received intrarectal diclofenac because we knew that we would work on the pancreatic duct. The other thing that we will do here, but we will do here for a therapeutic purpose, is the placement of a pancreatic stent to prevent post-ERCP acute pancreatitis. But in this case, we don't want the stent to be a stent without proximal flaps, which will spontaneously migrate, but we use a stent with two flaps, as you see, which will stay in place for 6 months before to be removed. And I think that in this particular case, after 6 months, if we can place two stents, I would not place a second one. I would just remove the two stents and see if the patient has a relapse of symptoms. So what I use here is the Oasis from Cook with an 8.5 French stent, which has been modified by Sonia to be a fusion inner guide. And as you can see, this is my guiding catheter. You see that the guide wire is entering the catheter on the side there. You see the guide wire there on the side. And then if you follow on the fluoroscopy, you will see that I will advance my catheter very gently towards the tail of the pancreas or the body of the pancreas. There, Sonia will help me to deliver the stent. Pardon? Pardon? I will, no, we will push the stent first, okay? So I'm advancing the stent. You see that this is important to stress that the stent is not only pushed by myself, but pulled by the assistant. You see the stent which is advancing. At this stage, if you can focus on the fluoroscopic image, tell me if you have it. Okay, you see that I'm pulling back the guide wire very gently. Okay, the guide wire is coming back up to the black marker, and there the guide wire is now free alongside my catheter. So I'm now pushing the stent. This is the proximal flap. I clean a little bit to give you a better picture. So we are in a good position. I open my elevator and Sonia is removing the inner catheter. Okay, okay, perfect. Then I remove the pusher tube and I have my guide wire which is ready for the second insertion. And for the second insertion we will use a 7 French stent, 5 centimeter. Again, the size of the stent is not very important when we place multiple stents. And one thing that we observed, you know that it was reported initially by the group of Roma, when we put stent for calibration, when we have more than one stent in place, there is no need to follow the former rule of exchange every 3 months or 4 months. You can really exchange a stent on demand or after 6 months. So in an advanced chronic pancreatitis, I would have done one exchange of stent and remove after 1 year. In this case, I think that the patient indeed had an acute pancreatitis, but we're at the very early beginning of the process of development of chronic pancreatitis. As it has been shown by EUS, the parenchyma is almost normal. So I think that in this case, the patient developed a scar in the head of the pancreas. And we are just trying to calibrate this scar for the long term.
And I think from the clinical point of view, it's very important because maybe in this patient we can change the natural history, because by treating this stricture, we will probably prevent the patient from developing a real advanced chronic pancreatitis with a lot of morphological changes in the parenchyma. So in this case...
Yeah. So just a small, before the question, I show you a small technical trick for those of you who don't do so much ERCP. So the pushing of a stent is always 3 elements. Open the elevator, push the stent, close the elevator, and if you are in trouble, you turn yourself and you torque the endoscope in order to apply the pressure with the endoscope. I'm sorry, please ask your question.
So, do you routinely place 2 stents for chronic pancreatitis in the pancreatic duct?
When the pancreatic duct is dilated, more than 3 or 4 millimeter, and we have a chronic pancreatitis, I always try to place more than 1 pancreatic stent. As you have seen, this was shown to shorten the duration of the calibration period and to decrease the required interval for exchange. There is also one pilot study which is ongoing on fully covered metallic stent, but I would not recommend to place in routine anything else than plastic stent in this patient. We can remove the guide wire.
Okay, Jacques, perfect. Very nice demonstration.